In this video, we'll first cover bioavailability and volume of distribution, then move step by step to half-life, steady state, maintenance dose, and loading dose. Pharmacokinetics often feels confusing because we learn these concepts separately, but in reality, they are all closely connected. By the end of this video, dosing will finally start to make logical clinical sense. So let's get started. When we take a drug, not all of the drug that we take reaches the systemic circulation. Some part of the drug is lost on the way to the systemic circulation. Therefore, bioavailability refers to how much of a medicine actually reaches the blood and can do its job. Suppose we have a glass of juice, and the glass containing the juice has a small hole at the bottom. Because of this hole, some juice leaks out before we drink it. So the juice that we actually drink represents the bioavailability, while the juice that leaks out because of the hole in the glass represents the first pass effect. In a similar manner, when we take a drug, it is first absorbed from the gastrointestinal tract and then carried to the liver via the portal circulation. From the liver, it finally reaches the systemic circulation. However, before reaching the systemic circulation, some amount of the drug is metabolized or removed by the liver. Therefore, the drug that is removed by the liver represents the first pass metabolism or first pass effect. Because of this, drugs administered by the oral route usually have lower bioavailability, that is, less than 100%, due to incomplete absorption and first pass metabolism. On the other hand, when a drug is given intravenously, its bioavailability is 100%. Because the drug is directly administered into the systemic circulation and bypasses the first pass metabolism. Drugs administered by intramuscular and subcutaneous routes are also absorbed almost completely. Therefore, their bioavailability is generally high, usually more than 75%, although it may not be exactly 100%. Bioavailability can be calculated by dividing the area under curve of the oral drug by the area under curve of the intravenous drug and then multiplying by 100. However, this calculation is not very important from an exam point of view. What is more important is understanding the concept of bioavailability, the role of first pass metabolism, and the difference between oral and intravenous routes. Let's do a quick question. What does a low first pass metabolism indicate? High or low bioavailability? First pass metabolism occurs mainly in the liver, where the drug is metabolized before it reaches the systemic circulation. This metabolism reduces the amount of drug that reaches the bloodstream in an unchanged form. Therefore, if a drug has low first pass metabolism, less of the drug is metabolized by the liver, which means more of the drug reaches the systemic circulation. Hence, low first pass metabolism indicates high bioavailability. The next is volume of distribution, describes how a drug spreads within the body after it enters the bloodstream. When we give a medicine by the oral route, it is first absorbed from the GI system and then it enters the blood. Once the drug reaches the blood, two main things can happen. On one hand, some drugs stay mostly within the blood and do not enter the tissues to a large extent. As a result, the blood concentration of these drugs remains high, while only a small amount of drug reaches the organs or tissues. On the other hand, some drugs leave the blood quickly and distribute deeply into body tissues such as fat, muscle, and other organs. In such cases, the blood concentration becomes low, while a large amount of the drug is actually hiding or stored in the tissues. Therefore, volume of distribution tells us whether a drug prefers to stay in the blood or spread out and hide in the tissues. A high volume of distribution means the drug is mostly present in tissues. A low volume of distribution means the drug is mostly present in the blood. Volume of distribution can be calculated as amount of drug in the body upon plasma drug concentration. So, If a drug remains mainly in the blood, the plasma concentration increases, and therefore the volume of distribution is low. Conversely, if a drug leaves the blood and enters tissues, the plasma concentration decreases, leading to a high volume of distribution. Factors that affect the volume of distribution include plasma and tissue protein binding, drug solubility, and drug particle size. When a drug is strongly plasma protein bound, it remains confined within the bloodstream and is less available to move into surrounding tissues. In addition, if a drug is non-lipophilic, it struggles to cross cell membranes, which are primarily lipid-based. As a result, the drug stays predominantly within the plasma. Furthermore, drugs with a large molecular weight find it physically difficult to pass through biological membranes, which again favors retention in the blood rather than distribution into tissues. Now, if we look back at the equation for volume of distribution, it becomes clear that when plasma concentration of drug becomes high, the calculated volume of distribution will be low. This perfectly explains why these drugs show a low volume of distribution. In contrast, drugs with a high volume of distribution display the opposite characteristics. These drugs are more likely to be bound to tissue proteins, are lipophilic, and generally have a smaller molecular size. When a drug binds preferentially to tissue proteins, it naturally accumulates outside the plasma compartment. Similarly, lipophilic drugs cross cell membranes with ease, allowing them to spread extensively into organs and tissues. Smaller molecules further enhance this movement by crossing membranes more readily. Because of these properties, such drugs quickly leave the bloodstream and distribute widely throughout the body, resulting in a low plasma concentration and a high volume of distribution. Drugs with a low volume of distribution include heparin and warfarin. On the other hand, drugs with a high volume of distribution include opiates and barbiturates. It actually makes a sense that drugs like heparin and warfarin have a low volume of distribution. Let's ask a simple question. What is the primary job of these drugs? Both heparin and warfarin are anticoagulants, which means their site of action is within the blood itself. Therefore, in order to exert their effect properly, these drugs need to stay in the bloodstream. Because of this requirement, these drugs are designed in such a way that they remain largely confined to the plasma rather than distributing into tissues. Therefore, these drugs have a low volume of distribution. Now, this property becomes extremely important from a clinical toxicity point of view. If a drug has a low volume of distribution, it means that most of the drug is present in the plasma. So, if a patient overdoses on such a drug, we can use hemodialysis to remove the drug from the blood effectively because the drug is actually accessible within the plasma compartment. In contrast, drugs with a high volume of distribution behave very differently. In these cases, most of the drug is distributed into tissues rather than remaining in the plasma. Therefore, during toxicity or overdose, hemodialysis is not very effective because the drug is not present in sufficient amounts in the blood to be removed. In simple terms, we cannot dialyze what is not in the plasma. So, to summarize this clinically important concept, a low VD drugs stay mainly in the blood, so dialysis can be useful. On the other hand, high VD drugs are mostly in tissues, so dialysis is ineffective. Now, let's apply this understanding with a quick question. What does a high volume of distribution tell us about a drug's binding preference? Does it favor plasma proteins or tissue proteins? Remember, drugs that bind to plasma proteins tend to stay in the bloodstream. On the other hand, drugs that bind more strongly to tissue proteins are drawn into tissues. Since a high volume of distribution reflects extensive tissue distribution, it clearly indicates that the drug is predominantly tissue protein bound. Next is, half-life is defined as the time required for the amount of a drug in the body to reduce to half of its original concentration. In other words, it is the time it takes for 50% of the drug to disappear from the blood. Half-life can be calculated by the following equation. It is important to note that this relationship holds true only for drugs that follow first-order elimination, meaning drugs in which a constant fraction of drug is eliminated per unit time. Because of this property, drugs that follow first-order kinetics require approximately 4 to 5 half-lives to reach steady-state concentration. This is a key concept and is commonly tested. Now, what do we mean by steady-state concentration? Steady state is the concentration at which the rate of drug administration becomes equal to the rate of drug elimination. At this point, the amount of drug entering the body is exactly balanced by the amount of drug being removed, so the plasma concentration remains constant over time. First and most importantly, the time required to reach steady state depends only on the elimination half-life of the drug. It does not depend on how large the dose is or how frequently you give the drug. So whether you give a small dose or a large dose, or whether you give it once daily or twice daily, the time to reach steady state remains the same, as long as the half-life is unchanged. However, for a drug to reach steady state, there is an important prerequisite. The drug must follow first-order elimination. As we discussed earlier, in first-order kinetics, the rate of drug elimination is directly proportional to the drug concentration in the plasma. This simply means that when the drug concentration is high, the body removes the drug faster, and when the concentration is low, the elimination becomes slower. Now, when we administer a drug repeatedly at fixed time intervals, the drug concentration does not reach steady state immediately. Instead, the drug gradually accumulates in the body over several half-lives. Why does this happen? Because after each dose, some amount of the previous dose is still present in the body. So, every new dose adds to the remaining drug already in the system. This process continues dose after dose until the rate of drug administration equals the rate of drug elimination. Now, let us understand this concept clearly by using a graph. On the x-axis, we plot time in hours, and on the y-axis, we plot plasma drug concentration, which simply tells us how much drug is present in the blood at any given moment. Step by step, suppose we give the first dose of 100 micrograms per milliliter. Immediately after administration, the plasma concentration becomes 100. Now, assume the half-life of the drug is 4 hours. Therefore, after one half-life, that is after 4 hours, 50% of the drug is eliminated, and the concentration falls from 100 to 50 micrograms. At this exact time point, we give the second dose of 100 micrograms. Since 50 units from the first dose are still present, the new plasma concentration now becomes 150 micrograms. This is a very important concept, as we discussed that when the concentration increases, the rate of elimination also increases. But the half-life remains constant because this drug follows first-order kinetics. Moving forward, after another 4 hours, again 50% of 150 micrograms is eliminated, so the concentration falls to 75. At this point, we administer the third dose of 100, raising the level to 175. After the next half-life, it falls to around 88. Then we add another dose, and the concentration rises further. This process keeps repeating, but gradually, you will notice that the rise and fall in drug levels becomes stable. Eventually, a point is reached where the amount of drug eliminated become almost equals to the amount of drug administered, and this is what we call steady-state concentration. From the graph, it becomes very clear that it takes about 1, 2, 3, 4, 5, so about 4 to 5 half-lives to reach this steady state. At steady state, the peak concentration represents CSS max, and the trough concentration represents CSS min. Clinically, our goal is to maintain the plasma drug levels above the minimum effective concentration and below the minimum toxic concentration. The area between these two limits is called the therapeutic window, and we want the steady state levels to stay within this window so that the drug is effective but not toxic. In this example, the repeated equal doses of 100 micrograms per milliliter given at fixed intervals of 4 hours represent the maintenance doses, which are continued to maintain the drug concentration within the therapeutic range once steady state has been achieved. So, this is the steady state. Now, let us move on to an important concept and understand what a loading dose actually is. When we talk about steady state, we already know that it does not occur immediately. Instead, it usually takes about 4 to 5 half-lives to reach steady state. In many routine situations, this delay is perfectly acceptable. However, there are several situations where we simply cannot afford to wait that long. For example, in conditions such as severe infections, acute arrhythmias, or ongoing seizures, where the drug effect is needed immediately, not after several half-lives. Therefore, instead of waiting for repeated maintenance doses to slowly build up the drug concentration, we give a loading dose. A loading dose is a large initial dose given at the start of therapy to rapidly achieve the desired therapeutic plasma concentration, essentially bringing the drug level close to what it would be at steady state. Once this target concentration is reached quickly using the loading dose, we then continue with regular maintenance doses, whose job is simply to replace the amount of drug that is eliminated and keep the plasma concentration stable. In simple terms, the purpose of a loading dose is to help us reach the effective drug level quickly, while maintenance doses help us maintain that level. Mathematically, the loading dose is calculated using this formula, and from this formula, it becomes very clear that the larger the volume of distribution of a drug, the larger the loading dose required.